Intrapartum Emergencies is the subject of this podcast, where we'll discuss just some of the emergencies, as in placenta previa, prolapsed cord, shoulder dystocia, amniotic fluid emboli, trauma, uterine rupture, and cesarean delivery. Hello, this is Susan Knowles from Cochise College Nursing, and welcome to this podcast. Placenta previa is one of those conditions that can actually cause or require the need for a cesarean delivery. When the placenta overlies the internal os of the uterus, essentially covering the entire birth canal or covering the cervical os, it prevents the baby from being the first to get out. The reason why the lay term for placenta is after birth is because that's when it's supposed to be delivered. So at the time of cervical dilatation, if the placenta becomes detached from the inside of the uterus, as it would, because as the cervix dilates, there's no place for the placenta to be attached, this will cause uterine bleeding or vaginal bleeding and can essentially break the connection so that the baby no longer has any perfusion, subsequently any oxygen, and causes third trimester bleeding. So in this case, if it should completely cover the cervical os, it would require a cesarean delivery, and the emergency is bleeding. So if a mom comes into labor with an undiagnosed placenta previa and is bleeding profusely, what would the nurse do? The nurse needs to avoid a cervical exam because you could disrupt the placenta even further and cause even heavier bleeding. So what you would do is you would, of course, call the physician, and they would order a ultrasound for placental localization to make sure that, or not really make sure, but to make sure, rule in or rule out, is this bleeding from a placenta that's covering the cervical os. Now, there are times when there's some third trimester bleeding and it's only a partial placenta previa, and there are circumstances in which a baby could actually be born vaginally if it's only slightly covering the cervical os, or it can move away from the cervical os as the pregnancy continues. Continuing on with the theme of placenta previa, there are cases where the placenta does not adhere to the uterine wall appropriately, and in this case the placenta actually grows partially or totally through the uterine wall. And the most prevalent type of abnormality would be placenta accreta, and this can happen in 75 to 78% of the time, where it grows partially into the uterine muscle. Increta is 17% of the time of the abnormalities with the placenta, and it grows further into the uterine muscle, and when it grows totally through the uterine muscle is called precreta. And in any of these cases, a cesarean delivery may or may not be performed at the time because it would not necessarily be known. But the woman will continue to bleed after delivery, and this would indicate further investigation, and if it is found that the placenta actually has grown into the uterine muscle and it only partially has been expelled after the delivery, it may require a hysterectomy postpartum in order to solve the bleeding problem. And in this photo on the slide, you will see a placenta accreta, where you can see that there is part of the placenta is actually embedded into the uterine wall. A prolapse cord is when the umbilical cord slips down after the membranes are ruptured. Either it can be compressed between the fetal presenting part and the pelvis, and it's not seen or felt during a vaginal exam. And this can be suspected because of fetal heart rate changes, and the fetal heart rate change that you should expect to see would be variable decelerations, because we believe this is associated with cord compression. Or the cord is not seen, but it can be felt as a pulsating mass during a vaginal examination. Or it can actually be protruding from the vagina itself. Compression of the cord can interfere with blood flow. It leads to decreased fetal oxygenation and potentially death of the fetus. Prolapse is more likely to occur when the fit between the fetus, or the presenting part, and the maternal pelvis is not good. So if the fetus is at a very high station, a -3 station as an example, and the bag ruptures spontaneously, or with a amniotomy, the cord can slip down in front of the fetal presenting part and actually protrude out of the vagina, or, as I stated before, in one of the other two options. Some of the other risk factors besides high station would be a small baby, or when the baby is breech, especially in a footling breech, because it's not the butt itself, it's actually a foot that's protruding or trying to present first, or in a transverse lie. We talked about this in the previous podcast, or in a patient who has a large amount of amniotic fluid or polyhydramnios. What is the treatment? What are our nursing interventions? Well, we have to position the woman's hips higher their head to shift the fetal presenting part towards her diaphragm or away from the vagina. We want to take the pressure off. Or she might be placed in a knee-chest position, Trendelenburg, where the hips are elevated with pillows, or maybe even in a side-lying position. If the nurse has gone in to do a vaginal exam and discovers the situation, she or he needs to maintain that vaginal elevation of the presenting part using a gloved hand while the patient is moved to the OR. Once the nurse is in the bed with the patient, the nurse does not leave. The nurse cannot take the pressure off of the cord. Now, you have to avoid any touching of the cord itself, because it can cause vasospasm. If the cord happens to be protruding from the the vagina, then a sterile sponge that is saturated with warmed, sterile water can be placed over the cord itself to keep it moist, because that's the normal situation that the cord is used to. And the nurse cannot leave the patient ever. So if you're in the bed with the patient and you need to call for help, you would pull the cord out of the wall if you need to, and you would then go to the operating room with the patient. The patient would be given tributaline to help stop the contractions. As I mentioned, sterile towels to keep the cord from drying out, and it needs to be warm to keep it from getting cold. No attempt should be made to reduce the cord, meaning push the cord back up into the vagina. The nurse should remain calm. This is probably one of the most difficult parts of all the interventions. Give simple explanations to both the family and to the patient to try to keep them calm. If you're the one that discovers that you're in the bed with the patient and the other folks need to do the other interventions, to call the team in for a immediate cesarean delivery. The next condition that can develop unexpectedly oftentimes is shoulder dystocia. Shoulder dystocia is when the head has been delivered, but either because the baby is presenting in a way where he or she is trying to come out with both shoulders at the same time and is not doing the appropriate cardinal movements, or because the pelvis shape itself does not allow the shoulders to come out with the anterior shoulder first and then the posterior shoulder second. But in any case, the first step is what's called the McRoberts maneuver, and this is where the assistant will actually, the nursing staff will have the mother put both of her legs up in the air as close as she can to her ears, or hyperflex the mother's hips against her abdomen, and this will help to rotate the symphysis pubis anteriorly and decrease the forces needed to deliver the fetal shoulders. And it has been studied and found that this maneuver is the safest and the most successful technique for relieving the shoulder dystocia. Then the assistant can add gentle suprapubic pressure while the physician continues to moderately apply posterior traction on the fetal head and help the delivery of the anterior shoulder. You absolutely do not apply fundal pressure because this actually increases the impaction of the shoulders. Of course, we go on, we hope that this whole thing works and the baby is delivered vaginally, and we would then record the time of the identification of the shoulder dystocia, the time of each maneuver, as well as the arrival of additional personnel. We lower the head of the bed, we place the patient in a supine lithotomy position, we use the McRoberts maneuver to open the pelvic girdle. We hopefully, if needed, we would empty the bladder with a straight cath. We apply the suprapubic pressure when the physician calls for it, and do the hopefully the internal rotation is attempted to free the body from the shoulder and complete the delivery. If the shoulders have not delivered with the maneuvers, other emergency steps could be to actually fracture the clavicle, and if that doesn't work, or if that is not tried, the head can actually be replaced in the vagina, and the patient is taken in for an emergency cesarean delivery. Amniotic fluid embolism, or anaphylactoid syndrome, occurs when the amniotic fluid is drawn into the maternal circulation and then carried into the mother's lungs. Fetal particulate matter like skin cells, vernix, hair, meconium in the fluid will then obstruct the pulmonary vessels, and it leads to hypoxemia and heart failure. This is an emergency situation. You could have everything going fine with mom, and all of a sudden she has abrupt respiratory distress, depressed cardiac function, and goes into circulatory collapse. It's rare, but it's often fatal. This is where you would have to institute CPR. The patient may need to go to the will go to the ICU, may be on a ventilator. She'll have to be given blood, immediate C-section to improve the survival of the fetus. She's going to exhibit hypoxia, hypotension. She may go into cardiac arrest. She can have coagulopathies like DIC, depressed ventricular function, cyanosis, bronchospasm, dyspnea. Cough is a cardinal sign. Pulmonary edema, chest pain, neurologic impairment, seizures, brain death, and multisystem organ dysfunction leading to death. Direct fetal trauma, such as a skull fracture or intracranial hemorrhage, can occur from a pelvic fracture, from penetrating wounds or blunt trauma, such as in a motor vehicle accident, gunshot wounds, or knife wounds. Indirect placental injury from abruption or secondary to maternal hypovolemia or uterine rupture can occur. Pregnant women have a higher volume of blood, which actually can give them a cushion against some blood loss. But when the mother is injured, blood is diverted from the fetus, and then the fetus may suffer from hypoxia, acidosis, and death. Uterine rupture is another emergency, and the patient could have a complete rupture, which is a direct communication between the uterus and the peritoneal cavity, or an incomplete rupture, which is a rupture into the peritoneum covering the uterus or into the broad ligament, but not into the peritoneal cavity. Dehiscence is where there is a partial separation from an old uterine scar. There may be little or no bleeding that can occur. Rupture is rare, but dehiscence is not that unusual. It's associated with a previous uterine surgery, a previous C-section, or a uterine surgery where they remove uterine fibroids. The risk of uterine rupture depends on the type of previous C-section scar. The risk is greater with a classic incision than with the low transverse, fan and still, or bikini cut, so to speak. It doesn't really matter what type of incision is done on the skin. It really matters what type of incision is done on the uterus. So if you had a patient that came in that was wanting to have a vaginal delivery after a cesarean, the most important information that we really need is what type of incision was done on the uterus. And those patients that have had a classic or vertical incision on the uterus are at high risk of rupture. And so those folks really would be safer to have a repeat cesarean delivery versus a VBAC, because it is not recommended. Other risks for rupture are someone who's had a lot of pregnancies, so high parity with a thin uterine walls, blunt abdominal trauma, such as in the previous slide where we talked about trauma from automobile accidents, gunshot wounds, knife wounds, any kind of blunt trauma, or from intense contractions. So someone who's either having intense contractions on their own, or if we are inducing them and they're having very hard, intense contractions with the Pitocin. And this is more likely with induction than it is with on contractions on their own. But in someone who is having an abruption, the classic symptoms that they are having are intense board-like abdomen contractions, and not only are they at risk of having bleeding from their abruption, but possibly if they've had a previous uterine surgery, they are at increased risk of uterine rupture as well. What kind of pain do patients describe? Abdominal pain and tenderness may be a ripping pain. They can have chest pain between the scapula, and it's related to the irritation of blood in the diaphragm. And this is sort of a classic sign. You can also see it with other kinds of conditions. Hypovolemic shock, patient's going to have tachycardia, tachypnea, decreased blood pressure, pallor. They're going to be cold and clammy, and they're going to be anxious and restless. Fetal signs you may see: late decelerations, reduced variability. So instead of having that moderate variability that we like, which is 6 to 25 beats of difference, up and down undulating pattern, we're going to see maybe a flat line. We're going to see minimal to a absent variability. We never want to see a flat line in a baby. We may see either tachycardia or bradycardia. If you're starting to see bradycardia, you're seeing a baby that's dying. Or you may see no fetal heart tones at all. That means the baby is no longer viable. The patient may not be having any contractions at all. If they have a complete rupture, it may result in a massive blood loss. The fetus usually dies, and of course the mother's at risk of death as well. So for a variety of different reasons, fetal distress or these intrapartum complications, women will have a cesarean delivery versus a vaginal delivery. Some of the things that we need to make sure are in place before the surgical procedure are like any other surgical procedure, in that the consent form must be signed, that the mother must understand the procedure. She may have emergency procedure where she'll have to have general anesthesia, but generally the anesthesiologist is available and the patient can still have a spinal anesthesia. Sometimes they already have an epidural in place, and so that can be redosed and they can continue to have that same anesthesia for the procedure. They'll need IV fluids, antibiotics, preoperative antacids. They're going to need to have a Foley catheter in place to keep the bladder deflated, if you will, emptied for the procedure, because the incision will generally be on the lower uterine segment, which is right near where the bladder attaches to the uterus, or lays right on top of the uterus. It needs to be emptied so it doesn't get injured. The patient will be moved into the operating room where a surgical scrub will be performed. A grounding pad will be placed on the patient so that capillary bleeding can be taken care of. And some surgeons use the cut cautery of the bovie to do their incision once they've gone through the skin. They'll do that with a regular scalpel blade. The patient will be tipped onto their left side, so they'll have a hip roll under the right side. We need to be as calm as possible for the mom, because this is a very scary situation, and supportive to the family, and hopefully even in an emergent situation the father or the support person can be allowed to come to the operating room. And it's important for us as nurses to support the family and make sure that they realize that this is not a failure because they needed a cesarean delivery, and that should they express those concerns or feelings, that we let them talk about it and we support their feelings, but also reassure them that this is not a failure. This was, like I use the analogy with a landing. Any landing that you walk away from is a good landing, even if it's kind of rough. So the fact that mother and baby can survive a situation that can be potentially life-threatening, it is a good delivery, and that there's nothing to feel guilty about. And yet they may be that their perfect labor and delivery experience that they were fantasizing about didn't happen, but they're still a success. Oftentimes the baby is taken directly to the nursery without the mother having very much time to spend with the baby, or if the mother has to be put under general anesthesia for the surgical procedure, she doesn't have the opportunity to be awake and alert when the baby is first born. So it's so very important that once the baby is stable and mother is stable, that both the mother and the baby have time for their bonding so that that relationship can be formed. Oftentimes the support person or the father is the one who has the opportunity to do that initial bonding and take that baby to the nursery after the delivery of the baby in the operating room. And this is a very important time for a father to have to bond with the baby. And as long as the baby is stable, then this can be a very positive situation. But even when the baby isn't stable, fathers are allowed in the nursery and can spend that time with the baby, and it should be supported by the nursing staff. And then always encourage that pictures be taken so mom can have a record of what was going on immediately after the delivery. Thank you for joining me on this podcast where we talked about just some examples of intrapartum complications leading to cesarean delivery. Thank you very much. This is Susan Knowles from Cochise College.